Hello everybody, Christina Previtt here for the Jerry PT version of PT on Ice. If you are new to the podcast, I am one of the lead faculty for the Modern Management of the Older Adult Division. I am joined often by my partner in crime, Dustin Jones. We alternate on Wednesdays. Over the last couple of weeks, it has been super busy in the Older Adult Division. We just finished off our last cohort, our online cohort of the Modern Management of the Older Adult. It was super fun. We had a great time with that cohort. Our next cohort starts in the middle of January, so if you're interested in getting on board, use that as a Christmas present or something to get some CEUs and learn a lot more about management of the older adult. We are also headed to St. Louis in a week and a half. I can't believe it, this course has come up so fast. So Dustin and I are actually both going to be teaching at HouseFit with Beth Templin over in St. Louis. So we're really excited to bring the live version of PT on Ice. So this podcast episode has been brewing in my mind. You're going to tell me that I have a Canadian accent saying stuff like that. For a long time. It often comes up when we're discussing exercise prescription with our online cohort. And so the topic is, what happens when we can't help our older clients, or they're not at a point where improvement is a realistic physiotherapy goal. And this was a topic that was always a real struggle for me. You know, and I'm sure I can speak for everyone, when we go into physiotherapy school or physical therapy school, the idea is that we want to help people recover from injuries. We want to, get them moving around in their community, improve physical function, optimize their quality of life, all of these things that drew us to this healthcare profession. I remember the reason why I wanted to be a physical therapist is because I worked in acquired brain injury, and I saw the improvements that the work of allied healthcare professionals had with the individuals that I was working with in terms of improving the quality of their life. And so the idea that I'm going to be working with somebody that I can't help is really a challenging construct for me. And when we think about how often we have to deliver really bad news in physical therapy, the answer is probably not that often. To be honest, when we see people, I'm in outpatient orthopedics, Dustin's in home care, so his situation may be slightly different. But oftentimes we can at least get some improvement in function, some improvement in mobility, some self-management strategies or ways to conceptualize around pain. And if conservative management isn't working, we'll say, okay, well, next step is for us to go for a more medicalized intervention. And we have people going for surgeries, for example, and a lot of my older clients, it's arthritis, and we're working on optimizing or staving off the need for a joint replacement or revision. And so that's kind of where the next step becomes a little bit more medical. But so it's very rare in our profession that we're going to have to say, I don't think that this is going to work, or, there's no point in continuing with therapy. And so there's probably two main areas, I guess, in rehab that we tend to see a stalling of progress or a lack of expectation of progression. And for one, that can be neurological populations, which isn't my forte, but we have individuals who are trying to optimize function with progressive MS, ALS, Parkinson's, those type of conditions, chronic stroke even. Sometimes we get to a point where we're trying to prevent secondary and tertiary complications. We're not necessarily trying to regain function after a certain amount of time. And the second would be probably in the very acutely ill or chronically ill. And this is kind of where we get into the home care, community care, acute hospital type settings. When we talk about aging as a reserve issue, as we transition through the medical system, we get more and more individuals who are coming in to see us who are getting progressively more sick. We're seeing individuals who have come in and out of hospital multiple times for falls, and transitions into institutionalized care may be the next best option in terms of optimizing safety and quality of life for these individuals when independence is not a realistic expectation. We have individuals who are coming in with exacerbations of chronic conditions, things that the APHPT is trying to avoid, but if it's manifested and it's starting to get worse, we're thinking chronic kidney conditions and all these type of things. In the geriatric world very broadly, these are when individuals are on the further end of the spectrum in regards to clinical geriatric syndromes. And we've talked a lot about these clinical geriatric syndromes being very, very important to PT practice because a lot of them, although they are a constellation of signs and symptoms across multiple organ systems, their presentation is often a very physical one and translates into a lack of ability to complete ADLs or IADLs or a lot of difficulty with completing these tasks. And so when I'm talking about the other end of the spectrum with the master's athlete, we are seeing these individuals with an extreme amount of reserve relative to their age. And this is where we're starting to combat some of that ageist sentiment. So previously, I would argue that sometimes we can make the false assumption based on an individual's age that there's no chance for improvement or there's no capacity to improve. We have studies now that are combating that ageist sentiment. We have examples of people in their 80s and 90s who still have a lot of physiological reserve and they're not close to that loss of independence line. We had the study that was done in Italy by Fiatorn and colleagues in 1990, which showed that an 8-week resistance training program for wheelchair-bound older adults in an assisted living facility saw an over 100% improvement in cross-sectional area and muscular strength of the quadricep muscles, which we would think would be extremely atrophied because of disuse being wheelchair-bound and not necessarily community or even house ambulation capabilities for these individuals. And so we're combating that ageist sentiment so that it's not just that we give up on our clients who are in their 80s because they're in their 80s. We try and improve their function and keep them living at home for as long as possible or as long as that decision is a sound one between the client you're working with and their families, for example. But now when we're looking at people on the end of the frailty spectrum, what we're seeing with these individuals, especially frailty and sarcopenia, these are two very physically manifested geriatric syndromes. Though I guess you could argue that urinary incontinence, falls, and delirium are also very physically manifested, though delirium, there's a big cognitive component, but I digress. So we know that with physical frailty, we have the 5 physical phenotypes. So we have unexpected weight loss, slow gait speed, lethargy, low muscular strength, and slow gait speed. A lot of these things, 4 out of the 5, I would argue that we are trying to improve with physical therapy outcomes. But if we have individuals who have 4 or 5 of these traits, and geriatricians would argue that especially with that unexpected weight loss piece, that prognosis is not very good. The question becomes, when does PT end? Are we just trying to optimize function? Are we trying to maintain things as long as we can? What the systematic reviews and a large body of literature is starting to support is that especially for these individuals who have 4 or 5 of these traits, who are very physically frail with a very complex medical history, we are starting to see that it is taking longer and longer because there's been further and further periods of deconditioning that are occurring for these individuals to get them back to a certain level of physical function. And that's very, unfortunately, comes down to dollars and cents. It's very healthcare intensive. It's very resource intensive. It requires a certain amount of motivation on the side of the individual. And as we know, if we worked with a lot of older adults, that if we have an individual who's very sick, they don't probably want to do very intensive physical activity or rehab. And so the question becomes, when do we stop? And so this is not a question that I feel like I can answer, but it's definitely a question that I reflect on. And so then the next question becomes, if we are gonna have very mitigated or minimal physiotherapy goals, do we discharge even though they need care? Or do we try to continue as much as possible? If we're seeing a failure to progress, are our regulatory bodies or our workplace, our funding models, depending on the area that you're in, are they kind of binding our hands and saying, well, we have to discharge because there's no improvement here? I know Dustin was saying a lot that in the States they're using more quality measures to justify rehabilitation standards. And so if we know that this person has a huge potential to recover, but they don't have the motivation, there's other things going on in their medical history, for example, that makes this challenging, at what point do we say, okay, we'll just try and maintain for as long as we can and see how you do? And the other thing, of course, that I haven't mentioned yet is the wants and needs of the client. You know, sometimes I can be guilty of trying to be this cheerleader who really wants to improve their function and get them doing X, Y, and Z, and that's just not what they want to do. They want to be able to transfer from their bed to their wheelchair, head down into the dining hall, and hang out with their individuals that they hang out with every day, and just have a certain baseline level of function. They don't want to be regaining all of these skills. And that's okay too. We have to respect that. But I think when we start getting into this side of the functional continuum, this is where we as healthcare providers, who I'm sure are coming from the best place because we really do want to be helping these individuals, can really struggle with, you know, what is the right thing to do, what is the right course of care. So I kind of wanted to bring up the other end of the continuum because, you know, I am a very optimistic person. I was a cheerleader in high school and university. I am like a sunshines and rainbows type of person and can feel really gut-wrenched when I see somebody declining and I feel like there's nothing that I can do to help. But I think these are really important conversations for us as a profession to be having because they're real and they're things that sometimes we struggle with. You know, we have some physical therapists who work in palliative care. So their goal is to try and, you know, alleviate pain and optimize their ability to live out the last couple of days, weeks, years of their life as pain-free and as optimized as possible, but they may not be, like, their goal isn't to have them returning to community ambulation. It's just getting them to stretch out their legs every day so that they don't feel cramped and really uncomfortable. So put a comment below. If you guys work in this setting or have struggled with this yourself, I would love to hear from you. I think this is a really important conversation. At what point do you think we need to stop rehab? At what point do you think we need to, you know, take a step back and reflect on our own desires versus the desires of our client? Or the desires of our client versus the desires of their family. You know, sometimes the families are like, yeah, I want my dad to keep going. And dad just doesn't want to. He's just not ready. You know, I talk a lot about my personal stories, and my grandmother, I tried to get her super active a couple of years before she really started to decline, and she didn't want to. So I tried giving her exercises, I tried going over and doing them with her, and she would kind of do them begrudgingly at the time. And then within a couple of months, a couple of years from there, the reason why she transitioned into assisted living was that she didn't have the strength to get up out of a toilet. And so because she didn't have that sit to stand strength, she would fall in the bathroom. And it just started exacerbating underlying conditions that were below the surface before. And so when people ask about kind of what happened to my grandmother, I say that she just didn't have the strength to continue, and nor did she want to have the strength to continue. She was at a point where she had lived a good life and she didn't really want to continue. And so she kind of let the aging process take hold of her, and she passed away shortly after that. And so, you know, these are hard conversations. These are not easy answers. These are ethical questions. Yeah, so Brittany was saying she definitely encounters this. Thank you for the perspective. You're very welcome. This is not something that I feel really comfortable in. I'm really outside of my comfort zone here, but I thought that it's a really good conversation for us to start to have as I start to tear up. So I hope that you guys got something out of this. It made you kind of think and reflect on your own practice. And if you have any, you know, comments or perspectives, I would love to hear them. And let's continue this conversation because I think it's an important one. All right, I'll see you guys later. Bye.